Ladies and gentlemen, before we begin today's program, please allow me to share some important health and safety information for your comfort and security during the symposium. In case of emergency, please remain calm and follow the instruction from the organizing committee.
Emergency exits are located behind the audience seating area. For your convenience, restrooms are located outside the auditorium hall. As courtesy, we kindly remind you to keep your mobile phones on silent mode during the sessions.
Good morning, ladies and gentlemen, distinguished guests, and colleagues. To begin today's event, let us welcome the opening dance beautifully presented by Tristic, performed by second-year undergraduate students dance club in the Faculty of Dentistry, Universitas Indonesia. They will perform Kinang Kilaras dance, a traditional Betawi dance that portrays the joy, spirit, and cheerfulness of Betawi women.
The dance reflects the happiness of graceful, beautiful, and dynamic of Betawi women, in line with the harmonious character of the Betawi community. Please welcome Kinang Kilaras dance. Once again, please give applause for Tristic, Faculty of Dentistry, Universitas Indonesia.
Ladies and gentlemen, may I now invite everyone to please rise for the national anthem of Indonesia.
Thank you. Ladies and gentlemen, you may now be seated.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, ladies and gentlemen. My name is Anatalia. I'm a first-year clinical program, and here with me,
Rivaldo Febriansyah, and will be your host, your today's event.
ladies and gentlemen, welcome to the Dental Research Symposium 2025, an international joint symposium hosted by Universitas Indonesia in collaboration with Chulalongkorn University and University of Malaya here at Depok campus.
The symposium serves as a platform for sharing knowledge, research, and collaboration among distinguished academics and researchers from University Indonesia, University of Malaya, and Chulalongkorn University.
Before we begin the scientific sessions, we would like to warmly welcome our honorable guests.
Professor Insinyur Mahmud Sudiban Rio, MSc, PhD, Vice Rector for Academic and Student Affairs, Universitas Indonesia.
Dr. Nia Ayu Ismianti, DDS MDSC, Specialist in Orthodontics Consultant, Chief Partnership and Entrepreneurship Officer.
Professor Lisa Rinanda Amir, DDS, PhD, Fellow of the International Association of Oral and Pathologists, Dean of the Faculty of Dentistry, Universitas Indonesia.
Professor Ponchai Jansianon, DDS MS PhD, Dean of the Faculty of Dentistry, Chulalongkorn University.
Professor Dr. Firdaus Hariri, BDS, MDS, MBBS, MSc, Dean of the Faculty of Dentistry, University Malaya.
Dr. Amalia Trisnantias, Specialist in Conservative Dentistry, Dean of the Faculty of Dentistry, Universitas Aisyah Prisengu.
Professor Dr. Retno Widayati, DDS, Consultant Specialist in Orthodontics, the Chair of the Board of Professors, Faculty of Dentistry, University of Indonesia.
Professor Dr. Eliza Herda, DMD MSc, the Chair of the Academic Senate, Faculty of Dentistry, Universitas Indonesia. All Vice Dean of the Faculty of Dentistry, Universitas Indonesia.
Representative of Indonesia Dental Association, Marsma Tekni Dr. Hairul Maulidi, Specialist in Conservative Dentistry.
The Manager, Heads of Departments, and Head of the Study Programs at Faculty of Dentistry, Universitas Indonesia.
All speakers and moderators for today's event.
Representative of Alumni Association of Faculty of Dentistry, Universitas Indonesia.
Partners and sponsors for the support from Pepsodent, Promere Harjo, Arista Dental, and Associate Hospitals.
All distinguished guests, respected colleagues, and participants who have joined us today.
Ladies and gentlemen, We will now continue with the Dean of the Faculty of Dentistry, Universitas Indonesia, Professor Lisa Rinanda Amir, to deliver an opening remarks. Prof. Lisa, the floor is yours.
Good morning. Assalamualaikum warahmatullahi wabarakatuh. Yeah. The Honorable Vice Rector of Academic and Student Affairs Universitas Indonesia, Professor Mahmud Sudibandrio, the Honorable Dean of Faculty of Dentistry, Chulalongkorn University, Prof. Dean Pornchai Yansis Yanot, the Honorable Dean Faculty of Dentistry, University of Malaya, Dean Firdaus Hariri, distinguished guests, esteemed colleagues, and dear students. It is my great pleasure to welcome all of you to the Joint Symposium of Dental Research Summit 2025. On behalf of Faculty of Dentistry Universitas Indonesia, I would like to express our deepest appreciation for your presence and participation during these important meetings. So the symposium is a celebration of the collaboration and friendship, bringing together the leading minds in dental education and research. It is truly an honor for us to join hands with two best dental schools in the world, Chulalongkorn University and University of Malaya, building upon the strong foundation laid by our former deans. This joint symposium will elevate our partnership to a new heights. And through this Joint Symposium, we reaffirm our shared commitments to advancing dental science, fostering innovation, and contributing to the betterment of the global society. A very special welcome to our students who represent the future of our profession. May this summit inspire you to pursue excellence, embrace collaboration spirit, and also carry forward the passion for innovation. I would also like to extend my sincere gratitude to all speakers for sharing their knowledge and expertise with us today, and to all our partners and the organizing committee led by the leadership of Dr. Benso Sulijaya, who the team has worked tirelessly over the past months to bring this event to life. So it is my sincere hope that this collaboration will continue to flourish, bringing the lasting benefits to our academic community and beyond. Thank you very much. Terima kasih. Selamat pagi. Wassalamualaikum warahmatullahi wabarakatuh.
Thank you very much, Professor Lisa, for your warm and inspiring remarks. Next, we would like to invite the Dean of the Faculty of Dentistry, Chulalongkorn University, Professor Pornchai Yansis to deliver an opening remarks. Professor Pornchai, the stage is yours.
Distinguished Vice Rector, Dean, Professor, colleagues, and students. Good morning on behalf of the Faculty of Dentistry, Chulalongkorn University. It is my great honor to have a chance to welcome you to this first International Joint Symposium, fostering collaboration and breakthrough in oral science. This gathering brings together three leading dental schools, Universitas Indonesia, University Malaya, and Chulalongkorn University. Each of our institutions is recognized for excellence in education, research, and service. But what makes today remarkable is our decision to work together, not separately, to share ideas and to support one another in advancing the field of dentistry. This symposium is not just an advancing in academic meeting, it is a platform for collaboration where researchers, clinicians, and students exchange ideas and build joint projects. A network for connection where friendships and partnerships will grow across the border. A commitment to progress where we combine our strength to bring better oral health to our communities. Dentistry today faces global challenges, aging population, the growing burden of oral disease, and the need to embrace digital transformation and AI. These challenges cannot be solved by one institution alone. By uniting our strength, we can accelerate innovation and improve care worldwide. So this is the first step of our journey that will continue with future symposia and collaborations. I truly believe this initiative will lead to joint research, publication, exchange, and lifelong friendship among our institutions. So finally, let me thank Universitas Indonesia, especially Dean Lisa, for hosting us with such warm hospitality, and University Malaya for their strong partnership. To our participants, thank you for bringing your expertise and passion. May this symposium inspire us to work together, create breakthrough, and strengthen our shared mission in dentistry. So, terima kasih, ขอบคุณครับ Thank you very much.
Thank you very much, Professor Ponchai, for your kind words. We would also like to invite the Dean of the Faculty of Dentistry, University Malaya, Professor Dr. Firdaus Hariri, to deliver the opening remarks. Professor Hariri, the floor is yours.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. And a very good morning, the Honorable Vice Rector, Professor Insinyur Mahmud, and my sister, Prof. Lisa, the Dean of Dental School, Universitas Indonesia. Also my brother from the North, Prof. Ponchai, the Dean of Faculty of Dentistry, Chulalongkorn University, former Deans Dr. Nia, and a few others, Deputy Deans, the Head of Departments, ladies and gentlemen. On behalf of Faculty of Dentistry, University Malaya, I would like to convey the best wishes and regards from our Vice Chancellor, Professor Insinyur Dr. Nur Azwan, as well as the icon alumni UI, Professor Zamri, who is also the Vice Rector in under Student Affairs, and everybody from the Faculty of Dentistry, University Malaya. As mentioned by Prof. Ponchai, we are living in a very challenging era of digitalizations, where information can be gathered just at the end of the fingers. So when I met Prof. Lisa and Prof. Ponchai in Singapore, somewhere in May, as mentioned by Prof. Lisa last night, the idea of having a tri-university symposium came from Prof. Ponchai. But I have to applaud and congratulate Prof. Lisa for being brave to take the responsibility of becoming the first host for this tri-university symposium. I'm sure she received a lot of support from the former deans, Dr. Nia, Prof. Linda, and so I think I met 4 former deans last night, as well as the organizing committee. So on behalf of everybody from thank you very much for the hospitality, the accommodations, transportations. We brought together 10 of our experts from Faculty of Dentistry to share knowledge, and hopefully we can enhance and strengthen the collaborations between various entities, from special care dentistry to geriatric dentistry, public health, periodontology, among others. Has an open door policy. We have been practicing strong collaboration with UI before. We have got like partners and producing lab results and papers together, among others. And we will do so whenever UI and Chulalongkorn wants it. So that's my word from everybody from looking forward for the fruitful day, and wish you an enjoyable day in UI. Thank you very much. Assalamualaikum.
Thank you very much, Professor Hariri, for the encouraging message. And now, it is our honor to invite the Vice Rector of Universitas Indonesia, Professor Insinyur Mahmud Sudibandrio, to deliver his welcoming speech. Professor Mahmud, the stage is yours.
Assalamualaikum warahmatullahi wabarakatuh. Good morning, all distinguished guests. The Honorable Dean of the Faculty of Dentistry, Universitas Indonesia, the Honorable Dean of the Faculty of Dentistry, Chulalongkorn University, the Honorable Dean of the Faculty of Dentistry, University Malaya, the Honorable Dean of the College and Hospital of Stomatology, Guangxi Medical University, the Honorable Deans of the Health Science Cluster, Universitas Indonesia, distinguished speakers from Universitas Indonesia, Chulalongkorn University, and University Malaya, our respected professors, our esteemed partners, our beloved students, and all distinguished guests. It is my privilege to welcome you to the Dental Research Summit 2025, an international joint symposium jointly organized by Universitas Indonesia, Chulalongkorn University, and University Malaya, with the valued participations of universities from across Indonesia. This symposium serves as a meaningful platform to share research findings, exchange knowledge, and strengthen academic ties among our institutions. The presence of distinguished speakers from these universities reflects our shared commitments to advancing dental science, education, and innovations. Beyond academic exchange, this gathering also represents the spirit of collaboration and solidarity among institutions in our region. By working together, we not only strengthen our own university, but also contribute to the global advancement of dentistry, ensuring that our research and innovation bring positive impacts to both scientific development and community well-being. I also wish to highlight the role of our students, whose enthusiasm and dedication will shape the future of dental science. May this symposium inspire them to pursue research excellence, uphold ethical practice, and build bridges of collaborations that transcend borders. I hope this event will inspire fruitful discussions, foster sustainable collaborations, and create meaningful contributions not only to our faculties, but also to the global dental community. I wish you all a productive and enriching symposium. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh.
Thank you, Professor Mahmoud, for the final remarks. We kindly request the Vice Rector to remain on stage to proceed with the gong striking ceremony as a symbol of official opening of today's event.
We would also like to invite the deans of the faculties of dentistry from Universitas Indonesia, Chulalongkorn University, and University Malaya, Professor Lisa, Professor Ponchai, Professor Hariri, and Dr. Nia, to join the Vice Rector on the stage for this special moment. Please welcome them with a warm round of applause.
With the striking of the gong, the Dental Research Summit 2025 is now officially open. We look forward to fruitful discussions and meaningful exchanges throughout the program. Once again, please give them both applause, a big round of applause.
I think we could probably take another photo sessions for this one. Okay, so we're gonna have a photo session. So we could just stay in the stage first, together, everyone. Once again, we're going to take a picture where we're going to face backwards towards the audience. Okay, you may kindly
Okay,
now
thank
return
you,
towards
Tuan.
the seats.
Ladies and gentlemen, we will now begin our first scientific session with the topic Forensic Odontology, Integrating Science, Ethics, Justice, and Humanity.
We would like to welcome Dr. Nurtami DDS PhD, Specialist in Forensic Odontology from Universitas Indonesia as our distinguished speaker for this session. The session will also be moderated by Dr. Eric Idrus DDS PhD, Specialist in Oral Biology, Universitas Indonesia.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Vice Dean Dr. Nia and also all the deans. Good morning everyone and welcome to the very first talk of the symposiums, and I would also like to give a special and warmest welcome to our colleagues and students from University of Malaya and Chulalongkorn University. It's a genuine pleasure to welcome you all in this Depok campus. This very first talk of the symposiums covers a field where science meets the law in the most compelling way, forensic odontology. This discipline, often pivotal in identifying victims of mass disaster or criminal cases. We are incredibly fortunate to have with us today a distinguished expert whose work exemplifies the rigorous standards and crucial importance of this specialty. Please join me in extending a warm welcome to Dr. Nurtami, a specialist in forensic odontology, a head of Indonesian College of Forensic Odontologists, and currently she serves as Secretary of UI Oral Biology Department, a former Vice President of UI, and a former Vice Dean of Faculty of Dentistry, Universitas Indonesia. She has spent decades consulting and working on high-profile cases across the country. Her insight is sure to illuminate the cutting-edge techniques and ethical challenges facing forensic practitioners today. Without further ado, please welcome Dr. Nurtami to the stage.
Thank you, moderator. Assalamualaikum warahmatullahi wabarakatuh. Very good morning to everyone. Sawadee. So it is an honor for me to be here today. My name is Nurtami Sudarsono. I'm from the Department of Oral Biology, Faculty of Dentistry, Universitas Indonesia. So in today's presentation, I will try to explore how forensic odontology contributes to human identification, criminal investigations, and also humanitarian work, highlighting its ethical importance and recent applications in Indonesia. So let us begin by looking at how this field has evolved. And ladies and gentlemen, because some sensitive materials will be displayed in my presentation, I kindly ask you for your understanding in not taking any pictures of the slides, and your cooperation is deeply appreciated. A dentist is not only responsible for promoting oral health and preventing disease to improve the quality of life, but also plays a significant role beyond the clinic. In the field of forensic science and law enforcement, dentistry extends into a specialized area known as forensic odontology. This branch of dentistry focuses on the proper management, examination, and interpretation of dental evidence. Such evidence can be crucial in identifying individuals, whether living or deceased, and also in presenting reliable findings to serve the cause of justice. Human identification is essential in both living and the deceased, and together with fingerprints, dental records, and DNA, they are the gold standard of forensic identification. Human identification is crucial in, for example, missing person cases, by identifying individuals who disappeared or whose bodies may be found in various conditions. In mass disaster situations, by identifying victims where there are many human remains and in a mass casualty event. And also, criminal investigation by identifying suspects or also victims of the crime cases. Identification in living individuals is required in handling cases where documentation is absent, falsified, or disputed, cases of athletes' age fraud, child labor, illegal immigration, human trafficking, and crime, which may involve individuals with fraud or no verifiable identity papers. Ethical concerns also come into play, as examinations must respect human rights and avoid any discriminations. For deceased individuals, the difficulties are even greater. In cases of advanced decomposition, drowning, burning, and dismemberment, visual recognition becomes almost impossible. So fingerprints may be destroyed by trauma or environmental exposure, and DNA analysis, very highly reliable, is often expensive and time-consuming, and sometimes also compromised by degradation or contamination. So dental identification, considered durable, depends heavily on the availability of accurate ante-mortem dental records, which are not always accessible, especially in the regions of limited dental documentation practices. Comparing ante-mortem and post-mortem dental data is one of the primary methods in human identification. But when forensic experts are faced with unknown remains, one of the first questions they must answer is, was the individual male or female? Or what race or ancestry did they belong to? And these questions form the foundation of biological profile and guide investigators towards restoring an identity. And to answer them, scientists can use several approaches. Various sex and race determination have been developed through research on Indonesian populations. For example, measurements of intercanine and interpremolar distances can be used to categorize remains as male or female. Mesodistal width measurements from Priambada charts can be applied also to determine sex in the Japanese population, or we can also choose other methods that are commonly used among forensic experts for sex determination. Similarly, for race determination, sorry. For race determination, a metric or non-metric approach can also be used to look at the ancestry of body. For example, a non-metric method can be applied by observing anatomical features such as shovel shape, anterior teeth, the shape of palate, palatal sutures, which may indicate specific racial characteristics. Now we are talking about age estimation, which holds a central position in forensic odontology with broad application in investigation process. For example, in case of age fraud, determining age is essential to distinguish between children and adults in relation to criminal sentencing. It is also critical in disaster victim identification, where the age of decomposed or fragmentary remains must be estimated when antemortem records are also unavailable. In immigrant and asylum cases, age estimation may help verify whether an undocumented individual is a minor or an adult. Similarly, in the adoption process, it provides confirmation of child's biological age when reliable birth records are missing. Beyond legal and humanitarian work, age estimation also contributes to anthropological research, assisting in determining the age at death of skeletal or dental remains. For younger individuals, methods such as Demirjian, Al-Katani London Atlas, and also the ADISTI method, which we developed for Indonesian population, are widely applied using parameters such as tooth development, eruption, and deciduous fruit resorption. For older age group, techniques like Lamendin method, based on periodontal recession and root translucency, and Lovejoy method, which relies on tooth wear and attrition patterns, are also commonly used. In addition, many other methods can also be selected. Depends on the conditions of the dental evidence available, depends on the case, and also ensures that forensic experts can provide the most accurate possible age estimations in each case. Age estimation in fetuses and infants is also crucial to determine viability, live birth, cause of death, and legal responsibility. Among the available methods, dental development is one of the most reliable tools, supported, of course, by others, such as skeletal, histological, or pathological findings. So in this case, we can see that a pale appearance on the gingiva on both upper and lower jaw, still no deciduous or natal teeth present, but a gummy pad already present. And there's a positive lung flotation test that means that the infant is still alive when after birth. So age estimation, particularly in minors, can be very complex. And this is need specialized competency. Facial reconstruction is a forensic technique used to recreate the appearance of an individual from their skeletal remains, most often the skulls. Of course, this is in a post-mortem condition. Its primary goal is to provide a recognizable likeness that can assist in human identification. We use anatomical knowledge of the skull, tissue depth markers, and population-based standards to rebuild the face in close approximation that can be compared with missing person records, photographs, or family recognition. The methods can be done manually, or now there are like available 3D imaging softwares. In this case, it was a case of when we were called to assist in the identification process for victims from a major transportation accident. In high-profile cases, such as terrorist bombings, this is a case from 2009 JW Marriott suicide bombing. The identification of victims can be extremely challenging because explosive forces often cause severe disfigurement, fragmentation, or burning of bodies, making traditional identification methods like visual recognition is, of course, impossible. So among the technique used, the facial reconstruction can be a powerful tool by carefully analyzing the skull and applying the anatomical standards, and we were able to recreate the likely appearance of a victim. This reconstructed face is then compared with the missing person, in this case from the police terrorist records or police terrorist database, photographs, and shown to the relatives of possible recognition. So post-mortem facial reconstruction can provide valuable leads in complex investigations, particularly when dealing with unidentified remains from large-scale attacks, which also support the pursuit of justice in example like a high-profile criminal case. Dental clinical forensic also is a branch of forensic odontology that focuses on the examination of the living victims of trauma, negligence, criminal acts based on oral or dental evidence. It serves to provide the integrated and comprehensive services for victims of trauma, negligence, sexual violence, abuse against men, women, or children. The oral and facial region is one of the most common sites of injury in abuse and violent events, and forensic odontology provides the framework to evaluate them for legal and investigative purposes. Dentists may be the first professionals to notice these injuries, especially if the patient avoids other medical care. So many injuries we found often occur in the head, neck, and face region, including broken or fractured teeth, dental trauma, jaw fractures, lip or tongue lacerations, bite marks, and oral lesions. Bite marks are commonly found in assaults, child abuse, and sexual violence. And the analysis of bite mark can link to the perpetrator or the suspect to a victim. Although now bite marks is a bit debatable in providing the evidence of bite marks, and the pattern of injuries may help differentiate whether this is injury from self-inflicted from the assault-related trauma. A forensic odontologist must secure the saliva traces of bite marks or other related evidence for further DNA or lab examination. A possibility of other oral manifestation from predicted sexual violence also need to be examined. Like, for example, there's an erythema or a cheek or lip biting. In forensic odontology, assessing the severity of dentoalveolar trauma is not only a medical matter, but also carries important legal implications. The degree of trauma can influence how a case is classified in court, whether it is considered a minor injury, serious bodily harm, or grievous assault. For example, a fractured tooth or alveolar bone injury may serve as an evidence of violence, abuse, or accident reconstruction, and the severity grading helps determine the level of criminal charges or penalties. In civil case, trauma assessment can affect compensation claims, such as the cost of restoration treatment, long-term disability, aesthetic loss, or even permanent impairment. In cases involving child abuse or domestic violence, detailed documentation of dental injuries provide objective evidence that can support legal proceedings and protect vulnerable individuals. Thus, the forensic odontologists play a critical role in bridging medical findings with a judicial process, ensuring all scientific evaluation of the trauma are accurately translated into a legal framework. Recently, one of our graduate students has established this severe grading of dentoalveolar trauma from forensic odontology perspective. So now, when we face or we found such cases, we can have a good guidance in the assessment of dentoalveolar trauma severity and its implications of the law, for the law. So, in conclusion, the forensic odontology stands at the intersection of science, ethics, justice, and humanity. As a scientific discipline, it applies the precision of dental knowledge to the complex tasks of human identification, supporting investigations that range from everyday legal cases to large-scale disasters and also high-profile cases. Yet, beyond the science lies an equally vital dimension, which is ethics. Every examination, every report, and every testimony carries the responsibility to uphold the truth, confidentiality, and respect for both the living and the deceased. In the courtroom, forensic odontology becomes a voice for evidence, ensuring that justice is informed by objective and, of course, reliable findings. In humanitarian context, it goes further, restoring name to the nameless, dignity to the deceased, and of course, what we all wanted, a closure to grieving families. These are the collaborators for my presentation and also the progress of forensic odontology at Faculty of Dentistry Universitas Indonesia, from our own faculty, from the Faculty of Medicine, and also Cipto Mangunkusumo National Referral Hospital, and Rumah Sakit Bayangkara Tingkat 1 Said Sukanto Indonesian National Police. And we also have several collaborators from Tokyo Institute of Science in the Department of Forensic Dentistry. My acknowledgement for the Faculty of Dentistry Universitas Indonesia, from both master program and specialist program in forensic odontology, and forensic pathology and medical legal from the Faculty of Medicine Universitas Indonesia, Cipto Mangunkusumo Hospital, Bayangkara Hospital, Indonesian National Police, and Forensic Dentistry Department, Tokyo Institute of College in Japan. Thank you very much for your attention. Wassalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Thank you very much, Dr. Nurtami. What an eyes wide open presentation, in terms of forensic knowledge and also the figures displayed there. I'm pretty sure there's a lot of questions swirling around the audience right now. So if you have any questions, please raise your hand. We still have plenty of time for discussion. Okay, while waiting for the audience, okay, we have from the ladies there.
Thank you very much. I want to. No, no, okay. Okay. Let me introduce myself. I'm from odontology forensic, postgraduate student in odontology forensic. I want to ask case mutilation. Okay, only found case odontology forensic. Only one found school in tengkorak, maksudnya school, not found searching for family in the vacation. Jadi only school in odontology forensic. I want to try to this. Okay, thank you very much.
Is there any questions? If it's not, then Dr. Tami.
Okay.
Yeah.
If I may confirm the questions. The question was if we only have skull evidence. Okay. Bahasa Indonesia nggak apa-apa?
Hanya tengkorak saja, Dok.
Yang ditemukan?
Iya, tidak identitas dari laporan keluarga tidak ada sama sekali. Laporan pengenal tidak ada.
Ada gigi nggak?
Ada. Only skull, tengkorak full, only skull.
Skeletal or just cranium?
Mutilation, case mutilation.
I feel like a consultant. So the most, I'll try to, is it okay to answer directly?
Yes.
Eric, okay. So the most important thing in working on a forensic case is to have an evidence. Like small or big evidence, like can be like body parts or whole body. If you have a cranium, yeah, or like whole body skeletal, there are lots of things that you can do. Please remember that the primary identifiers are the fingerprints, which in a skeleton we cannot use that, but we still have hope from dental and DNA. If you don't have antemortem data of the person, tidak ada. Okay. If you want to have a dental data comparison from AM and PM, antemortem and postmortem, then you should have both. But if you don't have either, for example, there are cases that there's only the antemortem data, but there are other cases that only the postmortem data, it will not work. So from the skeletonized body or from the cranium, you can at least determine sex and race, and if you have teeth or like from the anatomical features, you can estimate the age. Yeah? From the cranium suture, you can estimate the age. But if you want to know who is Mr. X, then you have to go through DNA examination. For DNA examination, you can obtain the samples from tooth, or you can take part of the bones from the skeletonized body to be examined in the DNA lab. So there are ways. The most important thing is you have an evidence of a body. In fragmented body remains, sometimes we need also to reconcile the body parts, whether it belongs to one person or not. Yeah? That's also through a DNA examination. So in our study program, a graduate study program, we make sure that our students have the competency of examining DNA for identification. Would that answer the question? Okay?
Okay, we still have time for one more question. Yes, Dr. Angki.
Very very interesting presentation, Dr. Tami. Thank you for the opportunity. As you know, there's a lot of new technology in forensic dentistry, like 3D and imaging. What is the pro and cons using this new technology comparing to the traditional one that you show us a moment ago? Maybe you can explain. Is it, of course, if we found now the imaging is, they can get the very good result, but there must be some, drawbacks about this imaging. Maybe you can explain it. Thank you.
To answer?
Yes.
Thank you for the questions, Dr. Angki. High technology is very helpful in identifications, imaging process with sophisticated tools. It's very helpful. But most of the case that we found is almost not ideal. And that's actually the challenge in forensics. For example, if we examine DNA, for example, the DNA in forensic is not like the DNA when we're doing DNA research in the lab. But usually we need to deal with what we call LCN, low copy number of DNA, which is very challenging to obtain the extracted DNA. So yes, to your questions, even in the tools in the DNA lab is keep developing. So in a country, we need to keep up with such sophisticated methods, actually. I just visited the headquarters of Forensic National Science in South Korea last week and got the opportunity to visit the Human Identification Lab. And they already use like 3D scanners for traumas in the body. Yeah. And in Indonesia, sometimes we have a challenge also to open the mouth of a cadaver or a dead body because of the face of rigor mortis sometimes make it like difficult to open. And if only we have an oral scanner with a small scanner can go into the mouth, it will be like easier for us to examine instead of do the jaw resection. So this is good technology will help us. But the cons are also about the financing about that. For example, in developed countries, they use what they call virtual autopsy. So they use like CT imaging. In Indonesia, CT imaging is still considered very expensive. So even Cipto Mangunkusumo Hospital, they don't want to invest a CT imaging for dead bodies. So you can, this is our situations. But actually, digitalized tools is very helpful in forensic investigation.
Okay, thank you very much. So due to time constraints, we need to close the discussion sessions. So thank you very much for Dr. Notami. Please big applause to Dr. Notami.
Thank you very much. Thank you.
Thank you very much. We also would like to invite Prof. Lisa to come up to the stage to present the certificate to our distinguished speaker and also moderator. Dr. Rick?
And we're also handing out the certificate to the moderator, Dr. Eric Idrus. Thank you very much, Dr. Nurtami and Dr. Eric, for the insightful session.
We will now proceed with our next session on the topic tumor immune microenvironment in oral squamous cell carcinoma and mucoepidermoid carcinoma clinical implications.
For our second session, we would like to welcome Associate Professor Dr. Risa Saisuparat from Chulalongkorn University as the speaker for the session. The session will be also guided by Dr. Masita Mandasari, DDS PhD, specialist in oral medicine from Universitas Indonesia as the moderator.
Okay, thank you, MC, for the introduction. Okay, I'm going to take over from here. Hello, good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. Good morning to the leadership of the university, Dr. Nia, to Prof. Lisa, and also all the vice dean, and also the leadership of our partner university from University of Malaya, University of Chulalongkorn, colleagues, and also beloved students this morning. Okay, again, my name is Masita, so I have the honor to chair our next session, the second session of today, by Associate Professor Dr. Risa Saisuparat. Her presentation is titled Tumor Immune Microenvironment in Oral Squamous Cell Carcinoma and Mucoepidermoid Carcinoma, a Clinical Implication. So I think Dr. Risa graduated from University of Chulalongkorn and also from University of Maryland, Baltimore. So I hope that today's session, she will share a very interesting knowledge and enriching our knowledge. So I hope all the audience can gain something from this lecture. So Dr. Risa, if you are ready, you're welcome to start your presentation.
Okay, thank you for invitation. Can I give it a try on the remote control? Okay, good. Okay, good morning, everyone. Thank you for inviting me to join this symposium, the first ever. I'm trying to do the figure yesterday. UI, CU, and UM. Okay, so I would like to share my findings from my research projects. The topic is tumor immune microenvironment in oral squamous cell carcinoma and mucoepidermoid carcinoma and its clinical implications. Here's the agenda of my talk. I will divide into 3 parts: tumor immune microenvironment, TIME, and then apply this concept to squamous cell carcinoma and then mucoepidermoid carcinoma. First, I will briefly touch on the topic TIME. Here's back in 2000, Professor Hanahan and Weinberg proposed the concept of 6 features, hallmarks of the cancer. And you can see like sustaining proliferative signaling driven by oncogene, or evading growth suppressor driven by suppressor genes. These are the common features. And then a decade later, they propose additional features like avoiding immune destruction and tumor promoting inflammation. So these 2 features come into interest, avoiding immune destruction and tumor promoting inflammation. And recent updates, more features were added but not mentioned here in this lecture. So the tumor mass is not just composed of transformed cells, but also composed of many stromal types like cancer-associated fibroblasts, endothelial cell, polycyte, and inflammatory cell or immune cell. In this talk, I will use the term tumor immune microenvironment, TIME. So TIME include many cells like macrophages, neutrophils, mast cell, T and B lymphocyte, and myeloid-derived suppressor cell. They can function either tumor promoting or tumor suppressing. This picture captures the cancer progression, starting from the far left here, tumor initiation, early stage of the tumor. You can see there are some immune cells like neutrophil, T cells, and NK cell inhibit tumor growth, but also the early hallmark of the involvement of the immune cell, you see T cells excluded at the border of the tumor core. But once tumor progresses, angiogenesis comes, giving nutrient to the cancer cells, a subset of the tumor cell intravasate into vessel and travel around the vessel and disseminated to the distant site, forming secondary tumor. This is the cancer progression. This complex picture, I would like to highlight those two circles. Once tumor progresses to the invasive stage, you have inhibitory immune checkpoints that involve in tumor progression. One of the key that I want to highlight is we have inhibitory mediators such as interleukin-10, INOS, TGF-beta that inhibit T cell function. So T cells are excluded and dysfunction, and this allowing to have tumor cell escape from immunity and become distant metastasis. So now I'm going to talk about the concept of TIME in squamous cell carcinoma. Squamous cell carcinoma is the most common oral malignancy, frequently affecting elderly male, lateral tongue, and from the mouth are the most common location. Clinical presentation can be varying, ranging from erythroplakia, leukoplakia, exophytic growth, or endophytic growth. I would like to present findings that I have done with my first three on the far left. Is my work with Dr. Rania Yunus, who is my long-lasting friend. And the bottom here is the work that I'm led by Dr. Jaluwat while he's in the residency training under my supervision. So the first one, soluble SIMAP4D in plasma of head and neck squamous cell carcinoma. Patient is associated with underlying non-inflamed tumor profile. As you know, head and neck SCC remains poor prognosis with limited survival rate. Histologic subtype include inflamed versus non-inflamed that could influence response to immunotherapy. SIMAP4D or SIMAP4D is a membrane-bound or soluble protein that involved in immune regulation and tumor progression. This particular study was aimed to investigate the potential plasma soluble SIMAP4D as a non-invasive biomarker reflecting tumor immune profile. So 104 head and neck patient was recruited, and we collected paired plasma and tumor tissue sample. Tumor tissue sample was undergone immunohistochemistry for SIMAP4D PD-L1, and we also did histologic examination, subtype tumor into inflamed, immune occluded, or immune desert. And then we measure SIMAP4D in plasma by ELISA, and a subset of sample was undergone nanostring analysis for study differential gene expression and immune signature. Here, the SIMAP4D expression, it was found in immune cell, both immune cell and tumor cell. Immune cell was, SIMAP4D was expressed moderate to strong, membranous or cytoplasmic. In tumor cell, it was expressed range from weak to strong, and histologic subtype, we found 52% inflamed, 40% immune occluded, 8% immune desert. On the immunohistochem picture on the left here, inflamed, you can see positive SIMAP4D cell intermixed with the tumor islands. In the middle column, you see immune occluded, positive SIMAP4D cell separated from the tumor island. And on the right column, you see lack of positive SIMAP4D immune cell. So then we measured the plasma SIMAP4D level. We found 25% of head and neck patients had elevated SIMAP4D, and elevated SIMAP4D found exclusively in immune occluded type. So a subset of sample was sent to do the nanostring, and we found in high SIMAP4D group, we found a gene upregulated involving fibrosis, invasion, and immune suppression. In the other hand, low SIMAP4D group, we found gene that is related to T cell activation upregulated. So in conclusion from this study, serum SIMAP4D in plasma is associated with non-inflamed tumor phenotype, and it could be SIMAP4D could be as a real-time, minimally invasive immune biomarker. Potential use, it could be used as to stratify patients for immunotherapy responsiveness, and we could identify tumor with immune exclusion phenotype. We suggesting that therapeutic potential of targeting SIMAP4D could enhance immune infiltration and sensitize tumor to immunotherapy. Next is the study we done in the oral squamous cell carcinoma cohort. So OSCC, as we know, is the most common oral malignancy. Traditional WHO histologic classification focus on cell differentiation, like well, moderately, poorly differentiated, but underestimate stromal or inflammatory features. Tumor microenvironment, including inflammation or stromal density, could influence prognosis response to immunotherapy in SCC patient. In this particular study, we aim to characterize OSCC histologic inflammatory subtype, also peritumoral stromal changes, to correlate with patient demographics, clinical pathologic features, and immuno-oncologic gene expression. 87 OSCC cases were prospectively collected. We classify tumor according to inflamed, immune occluded, and immune desert, like previous study. But we also classify peritumoral stromal area into peritumoral stromal inflamed, meaning inflammation surrounding peritumoral area. Also tumoral stromal fibrosis, meaning fibrosis, fibrous tissue surrounding tumor. And then PTSF subdivided into diffuse stromal fibrosis and fibromyxoid stroma. We also did immunohistochem for SIMAP4D, and 8 cases were submitted to run nanostring differential gene expression. So here we have 56% inflamed. The first row pictures are inflamed type, 36% immune occluded. The middle column immune occluded, you see inflammatory cell, immune cell separated from the tumor islands. And then immune desert, just 8%. The bottom row is the example of the immune desert. So what we found, we correlate histologic feature with demographic finding, and we found peritumoral stromal inflamed subtype more frequently found in females, non-drinkers, and smaller tumor. In contrast, that one is associated with better tumor behavior. In contrast, peritumoral stromal fibrosis correlated with males, smokers, and history of alcohol consumption linked to larger size and advanced stage that refer to poor behavior. So conclusion from this study, OSCC stromal and inflammatory patterns correlate with demographics and tumor behavior. So for feral profile, we found in females, luckily females, non-smokers, non-drinkers, and tends to be inflamed tumor with peritumoral stromal inflamed. Unfavorable profile, we found in males, smoker, and history of drinker, and more often histology of fibrotic tumor. So we propose this histopathologic parameters could be complemented with the routine OSCC histologic grading. These findings highlight translational potential of TME-based stratification for prognosis and immunotherapy selection. This is another study of OSCC, but this time we look at the tumor margin of the surgical specimen. Okay? OSCC often arises from morphologically altered mucosa at the tumor margin. So tumor margins are ideal place to study early molecular changes in malignant transformation. Immune system interaction, particularly immune tolerance, are the key to tumor invasion. In this study, we were interested in PD-L1. So PD-L1 and interferon gamma are central to immune checkpoint regulation and tumor immune evasion. Aims of this study to investigate, to identify immuno-oncologic signatures at the tumor margin compared to the invasive tumor core. In this study, 73 cases with normal or dysplastic margins were recruited. We did immunohistochemistry for PD-L1. PD-L1 expression was assessed in epithelial and immune cells of the tumor margin. Gene expression was done. We also did the cell line experiment on oral potentially malignant cell line treated with interferon gamma. So here, PD-L1 expression, 85% of normal margin and dysplastic margin show PD-L1 positivity in epithelium, the brown positivity. 97% show PD-L1 positivity in the underlying immune cells. So those dots, brown cells, are the immune cell. We found it's a significant correlation between epithelial and immune cell PD-L1 expression. Gene analysis was done. PD-L1 interferon gamma 6 gene signature down-regulated in tumor margin compared to the tumor core. Tumor margin show higher CD8 T cell, macrophages, and dendritic cell, while T at the tumor core show upregulation of exhausted CD8 cell, TRK, and NK cells. Here, the cell line experiment we did with dog cell. Dogs is the oral potentially malignant cell line. And here on the Western blot, on the B figure, you see PD-L1 expression increase on the interferon gamma treatment, and it's regulated by phosphostrate 3 and mTOR pathway. So in conclusion from this study, PD-L1 expressed in tumor margin epithelium and immune cells may serve as a biomarker for malignant transformation. Interferon gamma plays a role in PD-L1 upregulation in oral potentially malignant cell line, contributing to immune escape. Tumor margin exhibit immune tolerant features, while invasive tumor areas show immune exhaustion. So novel immuno-oncologic transcriptional signatures identified at tumor margin and tumor area may guide future immunotherapy strategies. Further validation in larger cohort is needed to confirm the findings. Now I'm going to move to this study done by my student. We kind of confirm the expression of PD-L1 in OSCC and oral epithelial dysplasia. So OSCC is, the most common oral cancer, often preceded by oral epithelial dysplasia, which is one of the most common oral potentially malignant disorder. Malignant transformation rate of the OED is about 10.5%. PI3K, AKT, mTOR via phosphorylated RPS6 regulate cell growth and protein synthesis dysregulation linked to OSCC. PD-L1 is immune checkpoint protein promoting immune evasion implicated in OED transformed to OSCC. This particular study aimed to investigate expression of PD-L1 and phosphorylated RPS6 in OED and OSCC and to study their relationship with clinical pathologic features. So this study, we found PD-L1 expressed in 87.5% OED versus 53.8% OSCC. Phosphorylated RPS6 positive in all OED and OSCC cases. In OED, oral epithelial dysplasia, we found higher percentage positivity and intensity of PD-L1 and also phosphorylated RPS6 compared to oral SCC. Okay, the first two row PD-L1 expression, and here's the picture of PD-L1 expression in SCC and OED. Here, the lower bottom picture, you see strongly expression of phosphorylated RPS6 in SCC and OED. In this study, we conclude that PD-L1 and phosphorylated RPS6 highly expressed in oral epithelial dysplasia, suggesting early activation of immune evasion and mTOR pathway in tumorigenesis. PD-L1 expression decreased in OSCC, but PD-L1 still correlate with larger tumor size. There is a significant correlation between PD-L1 and phosphorylated RPS6, support a link between mTOR signaling and immune checkpoint regulation. These findings highlight potential roles of PD-L1 and phosphorylated RPS6 as biomarkers for malignant transformation and therapeutic targets in OSCC. So next, move to mucoepidermoid carcinoma. Mucoepidermoid carcinoma is the most common salivary gland malignancy in adult and children. Histologic grading could be low-grade, intermediate, and high-grade. Low-grade tumors shows good prognosis. Intermediate and high-grade tumors show bad prognosis. Patient could get lymph node and systemic metastasis. Here is the study done by my PhD student, Dr. Wee. Now she's back home in Vietnam, and I already gave her the blessing. She did several publications with me, but this one is related to the talk today. This study was to characterize the immunoarchitecture patterns and immune cell profile in MEC, and to evaluate prognostic signature of immunoarchitectural patterns and their potential relevance to immunotherapy in MEC. So what we found, we recruited 41 MEC cases, and we studied the immune cell distribution. We found immune poor. The first 3 pictures is they are the example of the histologic picture of immune poor. The bottom H&E pictures, they are example of the immune rich. We found 73% immune poor, 27% immune rich. And then we look at the T cell density in the tumor mass and margin. We found T cell density in eye-rich tumor across all compartments, tumor core, inner tumor margin, and outer tumor margin. A higher cell count found at the inner margin compared to the tumor core. And here, CD45 highlight immune cells in immune poor and immune rich. So MEC tumors could be from minor gland and major gland. MEC tumor here from those from major gland and high grade, usually they are significantly associated with eye-rich phenotype. Prognosis findings, high-grade MEC we found associated with recurrence and metastasis, the red line here. Eye-rich tumors correlated with poorer short-term disease-free survival. So conclusion from this study, MECs show heterogeneous immune profile. Majority are immune poor, immune-rich tumors linked with high-grade and aggressive disease. Abandoned T cells do not equal improved prognosis, suggesting T cell dysfunction or exhaustion. Evaluation of T cell lymphocytes, especially in the inner invasive margin, may offer insight in tumor behavior. All these findings highlight potential implications for immunotherapy development in MEC. And this is still ongoing study. This is the spatial study analysis of immune signature. Dr. Wee, she's back home, but she still has some work to do, to be thinking of me all the time. So conclusion from my study, tumor immune microenvironment plays a vital role in OSCC and MEC. In squamous cell carcinoma, plasma CMAP4D serve as a minimally invasive biomarker reflecting immune occluded phenotype. Stromal and inflammatory patterns in OSCC correlate with demographics, tumor behavior, and prognosis. PD-L1 expression at the tumor margins and invasive tumor site highlight immune tolerance versus immune exhaustion. In MEC, majority are immune poor, immune rich phenotype linked to high grade and worse prognosis. Abandoned CD3, CD8 T cells does not equal improved prognosis, indicating T cell dysfunction or exhaustion. Evaluation of T cell lymphocytes, especially at the inner invasive margin, may inform prognosis assessment and immunotherapy strategy. Last but not least, I would like to acknowledge my collaborator, Dr. Rania Yunus. She now affiliated with University of Alexandria in Egypt, and Dr. Zhao Ferrinuno, he's a faculty member in our school, and all collaborator, Dr. Kromkit from medical school, Dr. Somanat from Sililat Hospital, Dr. Nikos from University of Athens, and my technician, Mr. Somchai. Funding support from National Research Council of Thailand, C2F, grant for my student, my PhD student, grant from Faculty of Dentistry, and also from Chulalongkorn University. Thank you very much for your attention.
Okay, thank you very much, Dr. Risa. That's a very interesting research that you have done. I think you've done it for a long time. I think if you can collect this many data, and I'm very amazed that you have a wide network in the world to make such a very good data in OSCC and also in mucoepidermoid carcinoma. So from this interesting presentation, I would like to invite the audiences to maybe give your question. And also when you ask your question, yes, thank you very much, I already see you. So raise your hand and then state your name and also your affiliation. Okay, so the first one is the male, yes.
Sawadika.
Sawadika.
Good morning, Professor. My name is Hilmi. I was staff at maxillofacial pathology in Erlangga and also oral biology in Gadjah Mada University. Yes, actually, I have a common interest in OSCC. Actually, I'm now currently working in the reactive oxygen species with the OSCC. May I know, is there any influence, especially generating the ROS and in the tumor microenvironment? As we know that ROS generation will cause whether it can be cancer growth or cancer inhibition. And the second question, may I ask, is there any transcriptomic approach for the SEMA4D? I mean, is there any specific, like, I'm also working in the microRNA. Is there any microRNA which specifically will induce or generate or express the SEMA4D, especially in the OSCC? That's all. Thank you.
Thank you.
I think you can directly answer.
So IROS might be linked to immune microenvironment somehow. So you can see many growth factor also drive into tumor progression. So IROS is the upstream signaling that drive tumor progression. I think it might be somehow related to tumor immune microenvironment as well, but it's not in my area of research. Sorry that I cannot answer your question for that. For transcriptomic analysis of microRNA, many study on microRNA in OSCC as well. But to name the specific microRNA, I cannot name that because I'm not in that. My research is not in that area. Thank you. The lady in the front.
Okay, thank you, Dr. Hilmi. So the next question, yes.
Test. Good morning. Thank you, Dr. Masita, and thank you, Dr. Risa, for the presentation. My name is Yasinta. I'm a first-year oral medicine resident at University of Indonesia. So my question is, how early in malignant transformation do PD-L1 and interferon gamma signatures emerge at tumor margin, and how could this timeline realistically serve as a window of opportunity for preventive immunotherapy? Thank you.
So that's a good question. How early? In oral epithelial dysplasia, actually there are so many oral potentially malignant disorder. In this particular, we just focus on oral epithelial dysplasia because it's the most common type of OPMD. We classify OED in mild, moderate, and severe, and we found mild epithelial dysplasia express PD-L1 higher number compared to other level. I would say from this finding, it could the involvement could start from the early stage of the oral epithelial dysplasia, and if we could detect or give a diagnosis of OED, either mild, it could be a candidate, but treatment protocol for OED now, still remains surgery, right? Even my epithelial dysplasia, some doctor might just watch and see because it's at the mild level. I cannot tell you, I'm not confirming, tell you that my epithelial dysplasia, we just give patient immunotherapy. I would not say that.
Okay,
Thank you.
So we still have time for another question, I think. Is there anyone from the audience? Please raise your hand and also state your affiliation. Okay. Please raise your hand so that the staff can see you. Yes, thank you.
Thank you so much, Dr. Risa and Dr. Masita. Thank you for your presentation that was very insightful. I am Rina Kartikasari from doctoral program, and we know that the latest hallmark of cancer is one of the hallmarks is senescent cells, and the senescent cells secrete SEASP. It is senescence associated secretory phenotype. And it is pro-inflammatory cytokines. And I want to know what your opinion about the senescence-based therapy for OSCC. Thank you so much. Maybe related with inflammation and tumor immune microenvironment that related with senescence.
Senescence. When you are talking about senescence, you mean apoptosis, right?
Yeah, the cell that irreversibly.
This another separate area, apoptosis, but you might find some link between apoptosis or senescence to tumor immune microenvironment, but it's separate features as well.
Yeah, thank you so much.
Thank you.
Is there any other question? Or maybe, Dr. Risa, may I ask my question to you? I'm very interested when you present about the SEMA4D. So you said it's a plasma-soluble molecules, right? And then this become a potential non-invasive marker for OSCC. However, in your research or in your opinion, is this better? Is this a better candidate for non-invasive marker rather than, I think most of the research that I've read lately is something that derived from saliva. But this one is a plasma soluble, right? So this one, do you think that this is better? And also the second one is that how close is this to real life application from your research? So is it ready to be deployed for our clinical work or is it still under work? Thank you.
is when you come to collect sample from patients, we would prefer to have minimally invasive method. Saliva collection would be a preferable method, right? But then saliva just secreted from salivary gland, circulate in the oral cavity, unlike blood that withdrawn from your body is circulating the whole body. So I would say some plasma sample would be more potential than saliva sample. And this is, even though it's a study done 5 years ago, it's not still in practice. We just propose that SIMAP4D plasma could be potential. It's not in the common practice yet. Maybe in the future, we don't know.
Okay, thank you very much,
Thank you.
Dr. Risa. I think there is one question from that side. Oh yeah, Dr. Eric. Oh, okay.
Okay, thank you very much for a very fruitful presentations. I'm Eric from Oral Biology. I'm interested to know how specific is SEMA4D as a marker for carcinoma cell, carcinoma cells, oral carcinoma cells. How specific is it? Do you think we can detect a specific tumor in the oral mouth since we use plasma? And I'm pretty agree with Dr. Masita. Saliva, I think, also can be a very potential tools for us, especially if we want to detect in the oral cavity. Yeah. So, what do you think about it?
So from our findings, SIMAP4D, high level of SIMAP4D related with the immune occluded subtype from this study. So we could it's not a specific marker for giving you diagnosis of OSCC. It's just could be telling you that this high level of SIMAP4D suggesting immune occluded subtype, and this tumor we could give anti-immunotherapy treatment. It could be just for candidate in subgroup of the patient. Yes.
Okay, thank you.
Okay, thank you, Dr. Eric. I think we had a very interesting discussion related to the research that Dr. Risa has done. We wish you good luck on your next research. I think if you found the breakthrough, it will be very beneficial for us in dentistry community. So thank you, Dr. Risa, for the presentation, and thank you very much for the attention, dear audience.
Thank you.
Thank you so much. So we would like to invite Dr. Nia Ayu Isminiati to come up to the stage for giving the present certificate to the speaker.
We would also like to invite Dr. Nia to present the certificate towards the moderator. Thank you very much, Associate Professor Dr. Risa and Dr. Masita, for the valuable presentation.
To all participants, we have prepared the snacks near the receptionist desk in front of the area. So please feel free if you want to take it and enjoy yourself.
Okay, moving on. The next session, we will discuss the training the eye to defeat oral cancer with Oral Detect.
We would like to welcome Associate Professor Dr. Zuraiza Muhammad Zaini from University Malaya as the speaker for this session. The session will be moderated by Dr. Vera Julia, DDS Oral Maxillofacial Surgeon from Universitas Indonesia.
Good morning, good morning, distinguished college honor guests and friends, professor and doctor. Again, welcome to International Joint Symposium held by Universitas Indonesia, University Malaya, and Chulalongkorn University. I am Dr. Vera Julia from Universitas Indonesia, and it is my great pleasure to serve as the moderator for this session. Our theme today is training the eye to defeat oral cancer with Oral Detect. Reflects our shared commitment to advancing early detection and prevention of oral cancer, a challenge that still claims far too many lives worldwide. And we are privileged to have with us Associate Professor Dr. Zuraiza Muhammad Zaini from University Malaya. Dr. Zuraiza is currently working as Deputy Dean of Research and Innovation at the Faculty of Dentistry, University Malaya, and also serve as Head of the Oral Cancer Research and Coordinating Center. She holds a PhD in molecular oral pathology from King's College London, and her expertise covers molecular oral oncology, oral potentially malignant disorder, and innovative diagnostic approach. With more than 180 citations and numerous international publications, Dr. Zuraiza has been a driving force in developing cutting-edge research for oral cancer detection. Notably, she has contributed to the development and evaluation of Oral Detect, a powerful training and diagnostic tool designed to enhance clinician ability to recognize early signs of oral cancer. And also, her leadership extends beyond research. She has served as president of the Malaysian Association of Oral Maxillofacial Pathology and Medicine, and she continues to inspire through her teaching, publication, and international collaboration. It is truly an honor to welcome her today to share her insight, and please welcome Associate Professor Dr. Zuraiza. It's time with us.
Thank you, Dr. Vera, for the nice words. Right. Okay. So today my presentation on training the eye to defeat oral cancer with Oral Detect. So I think we will move on to the presentation. So as you see here, this is Professor very familiar with, and I think Prof. Chai as well. I think some delegates from Chulalongkorn who has been there last 2 years. Okay. So we have sorry, not yet. So that's, we have 4 buildings, 4 blocks. As you see that the tower where the specialists and also the postgraduate tower, what we call that. So we have multiple levels for different clinics for different specialties. As you see the tower there, while the rest, the not so tall, there are the blocks for, we have the undergraduate complex, and also we have the administrative building, the one in the middle between. Okay. Right. Okay, so oral cancers. Investing in oral cancer control and also prevention and the implementation of research will ensure that all people benefit equally from advances in cancer research. This statement from the National Institute of Health. What is oral cancer? I think we all know this is a global health issues with the Global Can in 2022 has reported that 389,000 new cases with 588 plus fatalities, with 5-year survival rate of 50%, which has been stayed at 50%, remained at 50% for many years. Why is this happen? Because usually it's the main cause or the main problem in the world is the delay in diagnosis. And also because why is it delay in the diagnosis? Because it's public do not aware of this condition. Although they know the oral cancer, but they don't know the pre-cancer or the potentially malignant disorders which can lead to cancer. So diagnosis delays are not only because of the public awareness, it also influenced by the patient, by the providers, which us, infrastructure, and also the health system. Okay, how do we control oral cancer? So there are two wings here where we increase the awareness, and also we do this screening to early detect the oral cancer. What is increased awareness? We promote self-checks or improve also oral health awareness. We promote also habit cessation. So the habits such as we all know, tobacco, bitter nuts, and alcohol. So public have to be aware of this. Early detection, the screening, where we do community screening, we can adopt as adopted by the developing countries such as Taiwan and Kerala, where they have oral cancer screening program at the national level, or chairside screening, where this is usually adopted by developed countries like United Kingdom, USA, and Europe. Okay, so for us in Malaysia, what was our response to oral cancer control? In line with this, OCRC, or Oral Cancer Research and Coordinating Center, was established in August 2005. This center, in collaboration with many other Ministry of Health hospital and also the Ministry of Health main administrator and other institutions like University of Science Malaysia and CARIF, now is Cancer Research Malaysia Foundation, own body foundation, and then we have other universities like University of National Malaysia and also University Technology Mara. Under Ministry of Health, as you see here, there are multiple number of hospitals that involved in this work. Okay. This was started by Emeritus Professor Zain in that time, and they worked together with all these institutions to establish OCRCC. Okay, what we do for the awareness, we have Mouth Cancer Awareness Month, which we celebrate on yearly basis. Okay, why usually it's in February? Why we do in February? It's coincide with World Cancer Day. So World Cancer Day, what we do, our center will go there, will do exhibition when they have this, like, this is our Minister of Health, where he has this this day of World Cancer Day with all medical as well as dental. So all the cancer, body, human cancer also involved in this big day. Okay, so now we move on to the early detection of oral cancer. What is early detection? It's to improve survival and decrease morbidity, and also by doing this early detection, it will decrease treatment costs. In early stage of cancer, it's usually asymptomatic and it's mimic benign condition, which is reducing the likelihood for the public to seek care. By doing screening, it provides an opportunity for early detection. The best approach to do early detection, usually we just do clinical examination, where patients come to us, we do this examination. So how However, we know that oral cancer is often preceded by clinical premalignant phase accessible to visual inspection. So with that, actually we have a window where we can do this early detection. However, this requires training to achieve comprehensive in recognizing oral cancer and oral potentially malignant disorders while differentiating from other similar lesions in the mouth. Why do we need trainings? To achieve accurate diagnosis clinically so that effective treatment can be administered. In research, why do we need training for early detection? To achieve comparable data across epidemiological studies and also to achieve valid and reliable estimate of prevalence. So further, all right, okay. So usually we do this for training, even not just the students, it's also for the health professionals, not only dentists. We also open up all this training to our medical colleagues as well as pharmacies. Okay, as I mentioned earlier, what about the training for health professionals? So we do training of trainers for the Ministry of Health specialists for them to then train their own doctors or dentists there, officers. And for the training of dentists or health professional, we do offer this training to develop expertise or skill in dentists differentiating and making decision on OPMD. Other than health professional, we also actually implement this program or detect this training to our postgrad as well as our undergraduate students. Okay, what is OroDetect? It's a structured training program which consisted of well-planned series that incorporated 3 powerful key as educational leading tool. So in the principle in this OroDetect program, we do test-enhanced learning, corrective feedback method, as well as spaced repetitive learning. Okay, what we meant by all those principles just now, we have before the lecture series, for number 2, we have pre-assessment. So meaning when students or the dentists come to that room, what we do, we test them with the number of spot diagnosis of pictures given for different lesions. And then we give lecture series. After that, we test again and then compare to the pre-assessment, whether they get a better result from the pre-assessment. Okay, and then after that post-assessment, we discuss the scores or what they have done, how they have done in the test for each lesion. I will show later. Then we do again the test and see how they can improve from when they come in with they have some knowledge, maybe not being brushed off, when we're being brushed, and then we do post-assessment 2, we again discuss, and the last one, the assessment 3, we expect from the pre-assessment to the third assessment, there should be improvement in the marks. Okay, so for the assessment, what we have in that each assessment, there are 20 cases. In all this assessment from pre to 1 to 3 assessment. So those cases are composed of normal oral mucosa, target lesion where we have cases of pictures or photos of oral cancer as well as OPMD. And while the non-target lesions actually are the normal mucosa, oral mucosa. And usually these 20 cases, we avoid using images of advanced cancers because our aim is actually to maybe do some revision. Cases, we also do the lectures to give like some revision to everybody as well, okay, before we proceed to the next assessment. Okay, so after they've done the pre-assessment, this is one of the picture that we put up, and then they have to answer the answer options are, as you see, case 4 there, A until G. So we have whether when you see this picture, what it is, then you tick what the answer is. Here I'm just showing you what we do in the corrective feedback, and then we discuss with them reason why the answer is correct or what is the answer there, and then also in relation to the overall information given answer to the questions. Okay. Okay, so in the assessment, when we put up this picture or this photo, and they see on their paper, or now we use Google Forms, the options A to G, and then for them to get some clues on what the lesions are, they are allowed to ask us, like what is the habit, for example. Like in this case, it's a lichen planus, so most of the patients, we allow the student to ask us like, is the patient coming for because it's burning, the patient has burning, and we say yes, or is the patient has bitten the mucosa for a long time, we say no, because it's more like to help the student as well to get the answer. It's actually lichen planus, so burning would be one of it. Or the next question, such as, is the lesion bilateral? Okay, so if with that two clues, they should be able to get the answer for, in this case, this is a lichen planus. Okay, so this is the view or the scene where we do this with our students. We do it in this like kind of hall because we have two. Usually we do in the hall like this, as you see, we put up the pictures there, and then the student can ask the two questions, and one below is actually Prof. Tilak giving a lectures in between. And at one point when we had COVID, we had to do it online. So as you see that's how the student participates. Okay, so our reminder whenever we do this, so we say, do not, discuss the answer, because we call it cheating, but the students say they just teamwork. Right, for our students, usually we run this program for one whole day. So as we start very early in the morning, and then introduction, as you see there, one whole day where we have the pre-calibration assessment before we start the lectures, then the lectures, followed by the assessment one, and then another then discussion of how they perform, and then lectures or talk before they're moving on to the next assessment. Okay, the results here from the scores. As you see, from pre-test to test 1 and 2. For our students, usually we just do up till test 2 because we want to run it only for one day, and especially for postgraduate students, why we stop at test 2. As you see there, they get 100%, so for us, there's no point of make another test, test 3. Okay, just I want to show here from test 1, pre-test, where they score quite low, and then they will increase to higher marks in test 2, test 1, and as well as test 2. Okay, this program we also conduct or run in our post-undergraduate students, where we start from, as you see, one whole day is like the whole program itself, it's 1 day or 1.5 day. For our students, we embed in curriculum, so we start in year 3, but in year 3, we only like do this for sort of like in introduction. So number 1 in year 3, because it's just first year of clinical year, so we teach them on how to do systematic oral mucosal examination. So in here, the series of lecture we introduce them how to do the systematic oral mucosal examination in order for them not to miss anything, especially in the oral mucosa, because usually for the dental student, they're very focused on just the teeth. So in this, what we call it this competency for year 3, because we want them to take it seriously although they focus very focused on the teeth. They also have to do this mucosal examination. And at this stage, we also introduce and make them know what are the variation in structures. So not the structures in oral mucosa, all are lesions. They might be just normal, but variation in structure and appearance of the oral mucosa. And then after this lecture, we bring them to the clinic and they will practice to do the systematic oral mucosal examination. For year 4, then we move on and cover a bit more, where we again do some revision of the recognizing disease of the mucosa, meaning the variation as well of all the oral mucosal lesion. And at this stage, we do the test. And we want to see, because after year 3, they have gone through all the lectures on oral pathology. So we expect in year 4, they should be able to know what are variation of oral mucosal lesions. Okay, so in year 4, usually we will give them this test and see whether they can, how well, or when they come back from year 3 and become year 4, whether they still remember what they learned in year 3 in oral pathology. Okay, but as it advances for year 4, we do this systematic oral mucosal examination, more just a lecture for a revision. And then we do this differential, we give also lectures on differential diagnosis of white, red, and mixed red and white oral lesion. And also oral pigmented lesions, ulcers and swelling. And then we do post-lecture tests and see how they perform. Usually for this year 4, we aim to make all of them to get the mark of scores more than 80%, okay? If they do not achieve that for after the second test, usually we have to call them, make another separate session to make them to get that 80% marks. Okay, now for year 5 only we do for the whole program. It's one whole day like we did for the postgraduate. Okay, so then for this series of lectures as well as all the tests from pre-test, post-test 1, 2, and 3. Okay, right. Okay, so all this, because we have been doing this for our students for for nearly 10 years. So we then, from all the marks and the scores, we publish, and then we did some study on from this program, and then we publish in Journal of Cancer Education to show that how effective this oral detect in enhancing the skill. Sorry. Get it back to now. Okay, so in this paper, we included a dental professional group consisting of OPOM and oral surgery specialists, periodontologists and restorative specialists, as well as general dental practitioner dentists. And we compared to the student group of 259, where because this program also runs in other university like there are Masa University as well as National University of Malaysia. So what we do when we do the statistic analysis, as you see here, for the overall score, okay, progress score by group. Dentists, as you see, when they start the pre-test, they obtain lower than 60% mark, And then as they go to the post-test 3, and they achieve more than 80%. And same goes to dental students, as you see there, some of them scored below 60, and then at the post-test 3, they go up, and some of them even score more than 90. Okay, so this still the same people effectiveness of oral detect. As you see here, this for graph, as you see, for different lesion. For leukoplakia, as you see, they do not recognize leukoplakia when they started at pre-test with below 40 mark. And then after the post-test 1, 2, and then up to 3, they reach up to 90% score. Okay, and as you see on the other side for the dentists, and then for the students, they score for leukoplakia, they start off again below 50, and then as they go to post-test 3, then they achieve up to 90% mark. Okay, so from this paper, we conclude that the oral detect is an efficient and effective competency tool which can be used to train students and dental professionals for early detection of OPMD and oral cancer. As I mentioned earlier, during COVID, we had to do this online, and then we again do some statistical analysis from all the scores and publish this in 2024. So we compare the conducting this program online versus physical. Okay, as you see, as I mentioned earlier as well, the mark increased from pre-test to post-test. As you see overall, patterns, and also for the face-to-face as well as online. So as expected, we would then see the increase of score until when they do at post-test 3. Okay, here as you see, for the age test, as you the face-to-face method, as you see, the increase in score is significant, and for when we compare post-test 1 to versus pre-test, and also when we compare post-test 2 scores versus post-test 1. Cohort D is being used as the effect measure, and as you see, the effect is quite significant and big and large, while for post-test 3 versus post-test 2, although significant, the effect size is quite small. For online method, the significance is found between the post-test 3 and post-test 2, and also post-test 1 versus post-test 2, 1. Here then we compare the scores of mean scores between face-to-face and online methods. As you see here, in online, when they do the pre-test, the mark is higher than when the student do face-to-face. But this is reversed when they did post-test 1 and also post-test 3, where the physical face-to-face conduct, they reach higher marks compared to the online method. Okay. Right, so this conclusion from this paper, F2F, face-to-face and online version of oral detect significantly enhance oral cancer detection knowledge and skills. Both methods are equally effective and suitable for the purpose of healthcare professionals and dental student skills development. Okay, when we talk about oral cancer, so the key questions are how is this controlling measures? How do we measure this oral cancer control? Number one, whether when we do all this prevention awareness program, how do we measure the success? And where can we get this measurable data? With having all this program of awareness, whether this program can also be adopted in another place or in another country. Okay, when we talk about data, the worldwide data reported to IARC, which under the Global Cancer Observatory, data reported by 185 countries via the National Cancer Registry, like from Malaysia. For Malaysia, we do this through Ministry of Health, Cancer Registry report. In this, when we submit the data, it has to be in histological form and coded in ICD. For oral cancer, is C00-C14. Why this coding play an important role on how the oral cancer rate will represent. As you see here, this one I just took what we had for all the Southeast Asian countries. So at this stage, our age standardized rate will per 100,000 incident for both sexes. As you see here, for Malaysia, Indonesia, we kind of like about similar, 2.3, while Thailand is still quite around 3.5. Okay, I just want to show here where when we OCRCC started, it was the ASR for oral cancer registry. In Malaysian Indian female, it was 14.5. Then because the latest that we had in 2022, but not yet like in very detail. So what I can get is only at 2016 from the Malaysian Cancer Registry. So from the 14.5, we decreased and reduced to now only 4.9 in 2016. Although it's not I cannot say it's OCRCC work, but because when we do this program, we do in collaboration with Ministry of Health and as well as other institutions. Back to the question number 3, whether this program can be implemented elsewhere. So I have Prof. Haizal in University of Otago. So he wants to implement this program to his place, to his students, and also to his population, his people there. So he invited me and then Prof. Emeritus Rusna, and we did the training there for them to start doing all this cancer screening. Okay, and then they did. And at that time, at the same time, we had our special care dentistry postgraduate posting. And before they went to University of Otago, they did the training with us first. And then we said then they go to Otago and they did the screening along with special care dentistry over there. We have Dr. Nurul and we have here Dr. Jessica. And a few postgraduate students, I know Dr. Asma. Okay. So to answer whether this program can be implemented elsewhere, yes, it can. But to measure how successful, we are yet to wait from Prof. Haizal in few years later down the line. So where to from now? We need to continuously reinvent and be in tune with current trend. Like now, vaping is in trend, so to see whether the oral mucosal solution from the result of vaping is there any difference, how it looks like, and then to also include that in our 20 combination of cases, just to see if to get people or the health professional and student also to be aware of. And then at this era where digital screening, I think, being promoted, although it's can be an adjunct, but it's not a holistic dentistry. We can use an adjunct, but it helps us, but not to be like the one that we really do in Oral Cancer Research and Coordinating Center. So we have this where we conduct research. We also do training, and we have biobank that we can provide data and specimen, and we also do community engagement. So under research, this the area of research that we do: cancer and molecular biology, diagnostic, epidemiology, clinical, as well as public health. So there are in our center public health specialists as well as members. As a resource center, biobank, so we also provide. Okay, so we have database of oral cancer and control. We also have specimen bank where people can come to us and ask for serum, myoplasma, or fresh frozen tissue, as well as FFPE. And from all this biobank, we also have a database on the socio-demographic, clinical, and details of patient. And here to show that we do training, responsible conduct of research module. And then we also do community engagement, where we do exhibition, mock screening, and workshop and seminars. And also we have patient support care program, where we gather all these patients, or SCC patients, and they support each other. I want to thank Prof. Emeritus Dr. Rosna Zain, who is now in Masa, and also Prof. Dr. Haizal, who is in University of Otago, and we have 2 research officers there and under OCRCC, Dr. Wan Maria Nabila, as well as Dr. Karen. Okay, with that, thank you.
Thank you very much, Professor Dr. Zuraiza, for that enlightening presentation. Your work with Oral Detect truly show us how innovation and education can empower early detection and improve outcome for patients at risk of oral cancer. Now we open the floor for discussion, but because the limitation of time, we only open for one question. Please raise your hand. Okay, Professor Yuni.
Thank you very much, Dr. Farah, for the opportunity. Thank you, Professor Zuraiza. Very nice to meet you again after last year, for the Global Oral Cancer meeting in KL. Very nice to meet you here. Thank you for sharing to us about the Oral Detect program done in and now is implemented in Otago University. My question is, because several years ago, actually, we have the honor to be trained by Professor Rosna because she collaborated with the Indonesian Association of Oral Medicine Specialists. And we actually, at that time, tried to continue the program by doing some training for general dentists for doing the Oral Detect program. And it was, we actually have to admit that we did that for the one and only time, so several years ago. And can you share your opinion whether the training, how long can actually the ability to detect of this lesion can actually be retained to the professionals? And can you actually suggest whether training is needed for them? Okay, that's my question. Thank you.
Thank you for the question. For my opinion, because it's actually a simple program where it's like one whole day program, but actually we also in the midst of trying to make this online version where, rather than they have to come to the program like one whole day, they can do this remotely by having sit for the pre-test exam. I mean, pre-test is actually before all these lectures, right? When they have the lectures, then they have the revision of all these different type of lesions in the oral mucosa. By doing that online or online, then we we will have what we're trying to do. So rather than they come to us, in like they have to spend day with us, they can do it remotely from where they are by doing this through the website. We're still working on that. But as you asking me the opinion whether they need this training, I do think so, because although we, especially dentists, when we work, we are very focused on the teeth treatment, right? Because when patient come to you, also they come to have the teeth done. Although some of them come to you for like oral complaints because they have painful ulcer or other lesions. It's just that because all these dentists, they are the like first line in health where they able to, when they able to identify or determine whether this needs to be seen by specialists. So it's a, I do think this program is needed for the, even for just general practitioners. So for our, why we implement to undergraduates, so we try to prepare them for this kind of ability for them to determine whether or not to refer these cases or need to be seen by a specialist right away.
Thank you very much, Dr. Zuraida. So because of the time is up, we have to finish this session, but first of all, I want to give the appreciate of your presentation, Professor Zuraida, because the oral detect program can reduce the mortality rate, because we have known that the oral cancer has a high mortality rate now because of the late of detection. So thank you very much for your inspiring presentation.
Please give them a warm round of applause. We would like to invite Professor Ponchai Jansiyanot from Chulalongkorn University to come up to the stage to present the certificate to our distinguished speaker. Professor Ponchai will also give the certificate towards the moderator as well.
Thank you very much, Associate Professor Dr. Zuraida and Dr. Farah for this session. Ladies and gentlemen, we will now continue with the next scientific session on the topic Orthodontics, Integrating Evidence-Based and Clinical Excellence for Better Patient Care.
We would like to welcome Dr. Benny Mulyono Sugiharto from Universitas Indonesia as our distinguished speaker for this session. The session will be moderated by Dr. Muhammad Sulaiman Kusuma Adiwirya, also from Universitas Indonesia.
Okay, good morning to the Dean and Vice Dean, also leaders from Universitas Indonesia, Chulalongkorn University, also University of Malaya. Good morning, dear Professor, faculty member, also dental colleagues. I am Dr. Arya. I will moderate this fourth session of the day with Dr. Benny Sugiharto as the presenter for the topic of orthodontics, integrating evidence-based and clinical excellence for better patient care. Please allow me to read his short CV. Dr. Benny Sugiharto graduated from the Faculty of Dentistry, Universitas Indonesia in 1998. He then obtained his orthodontic training and doctorate degree from Eastman Dental Institute, University College London, UK. He finished his specialist in orthodontics adaptation program from the University of Indonesia in 2008. He also received his consultant in orthodontics in 2017. He currently holds academic position as a senior lecturer in the Department of Orthodontics, University of Indonesia, and now he practices as a specialist in orthodontics at private hospital and at his own private practice in Jakarta. Without further ado, Dr. Benny, you may begin your presentation.
Thank you very much, Dr. Arya. Can I have the slides, please? Thank you. So good morning, everyone. I hope everybody is still awake. First of all, I would like to say good morning, and I would like to thank first for the Dean of the University of Indonesia, Prof. Lisa, for giving me the opportunity, or probably rather pushing me to do this. Thank you very much anyway. But can I also just welcome all the colleagues coming from the Chulalongkorn University, Sawadika, and also to the colleagues from University of Malaya, selamat datang di Indonesia. When I was asked to give this lecture, I was a bit confused, as the audience were a bit general, so probably we're not going to be talking in detail about the orthodontic itself, but we're probably going to be a bit more showcasing of what are we doing in our department in the university. So first of all, probably I choose the topic, and I've asked the approval of my dean to do this, is the orthodontics integrating evidence-based and clinical excellence for better patient care. As you may know, in my specialty, there's a lot of sometimes conflicting evidence, especially when we are concerning with industries. So can I just check whether this works? Probably is better. I think I may have to walk around because I don't think the receiver can accept the pointer too far. So this is a picture of a great actress in the 90s during my generation, with this Cameron Diaz, but I have to close the eyes because just to avoid any copyright infringement. But the point is, I'm talking about perception, whether her career would have taken off like what she had her teeth look like that. What about all these patients of mine with some severe malocclusion? And I think one of the challenges as well is the effect of this malocclusion to the psychosocial development of the individuals. And I think if everyone can agree that in these cases, definitely the perception of having this kind of malocclusion would definitely be detrimental. Now we're talking about another issue here, Prince William. Somehow I named my first son William as well. I named it because of him. Hopefully he will get a nice girlfriend as well, the same like his wife. But Prince William, many years ago, was caught up by the horrendous British tabloid of raising his middle finger like that. And it became a controversial issue. I can't remember in which year. It became a controversial issue. And after several days, I think there was another British media that posted a different angle where actually we could see he was raising all three fingers, not just the middle finger. The point of this picture is not talking about Prince William, but it's actually talking about the importance of having perspective. The previous one, we're talking about perception, which is our individual perception. Perspective, we're talking about bigger picture, about the different angles. And this is what I'm trying to talk about today. Same thing like this picture as well. Everything depends on how we want to look at it. And as far as possible, we want to look at every angle as possible. Obviously, the objective of orthodontic treatment in general, we want to restore function, we want to achieve aesthetic harmony, and obviously we want to support good psychosocial development. Okay. No? All right, sorry. These are the type of the skeletal malocclusion that becomes our daily diet as a clinician, with different scale of severity, on each of the malocclusion. In the next slide, we can see the variations that we can see in class 2 malocclusion, be it dental or skeletal, or prognathic maxilla or rectic mandible. And the same thing happens for class 3 malocclusions then. But then the question is, as clinicians as well, what do we have? What can we do? What do we have as our armamentarium? We have plenty. Now with the nowadays, the contemporary orthodontic treatment, we have the old removable British style appliances. We also have the clear aligner therapy. I'm not going to mention the name, but we have many names now. We have growth modification, fixed appliances, TADS, extraction or non-extraction. There are all these issues that are ongoing at the moment, as well as also multidisciplinary treatments that we have to work together with a team, with other colleagues from the surgery, pros, perio, endo, pedo, and everyone. But then again, there are always controversies that we have. The point that I'm trying to show here is what we are teaching our students is we want them not just to be a good clinician, but also becoming a critical and competent individual, not just following what we call as FOMO, or fear of missing out because of marketing. On the left, we have the so-called prefabricated functional appliance. And on the right one, we have the so-called customized functional appliance. I was still trained when I was in London with the same custom functional appliance. But nowadays, we are seeing an increasing number of people using the prefabricated one. But then the point is, what does the paper say? These are the papers coming from highly accredited individuals. And a lot of this, from the systematic review, saying that the prefabricated one have limited capabilities in treating malocclusion. And we replace and changing the gold standard of the customized myofunctional care. And then the next controversial issue, which one is better? Traditional fixed braces or clear aligner therapy? This is the ongoing debate at the moment. Very hot, actually. Certain papers, and these papers were written by highly accredited individuals. The left one of my friends wrote it, Nicholas Schweit, the president of the World Federation of Orthodontics. And they say, I have to back up the names because it implies a certain brand. So I don't want to be like doing a negative campaign about a certain brand, but we call it a clear aligner. But a certain brand has claimed that their software so good that they feel the predictability becomes very accurate. But it's not. Of the certain movement become as low as 28% predictability. That was in 2020, just before COVID. Previously, in 2017, also looking at the PAR index, they're looking also of a amount of PAR compared to the result of traditional fixed braces. And then the next paper, there we go, okay. This is a systematic review, again, published in the European Journal of Orthodontics. Similar results, arguing about the less predictability of clear aligners. And then this is the new one. I got my friend Professor Ravinanda just texted me 2 days ago and said, Benny, we just wrote it and published it in the AJODO. Can you read it? So they were discussing for 36 experts around the world of who does clear aligners a lot. And again, I'm not going to publish the whole thing here, but the result should be making us more becoming rational in our selection when we are giving the patient the treatment mechanics. So when we are trying to give our patient a treatment, there's a lot of consideration that we need to give. And I think I need to remind everyone again with what my professor once said when he lectured at the Eastman, who is Professor Kevin O'Brien, is about evidence-based care, which is a combination between your clinical experience, clinical research, as well as patient opinion. And this is where the evidence-base comes from when we are trying to give our best to our patient. Should I change this? Okay, thank you. Thank you very much. So what I'm trying to show is, these are the cases that were treated by my residents throughout their residency. and some of them would show gross malocclusions. But again, first case I would like to show you is simplifying the malocclusion. Sometimes the malocclusion can be as severe as this one. So I asked my residents, it would be hard if we want to straight away jump into fixed braces. So we both designed an old-style removable appliance, very British one. And a lot of people, when I made the seminar like this, came to me and say, isn't it outdated? It's old school. I love old school. If it works, why not? Purpose is not to finish the malocclusion, but to simplify my next stage. And the importance with this removable appliance is, as long as you know how to design and what to expect, it may work. Of course, in a limited way. You see, the severe scissor bite was corrected already. And that helps my resident in progressing to the next stage with the fixed appliance stage. Again, with removable appliance, we need to be realistic. And that's expected the same thing when you're doing with clear aligners as well. And then we have growth modification on a growing child, on a severe class 3s. This was also done by one of my residents, just graduated, actually the wife of my moderator. Thank you, Dr. Arya, for allowing me to use this. You can see growing kid, severe class 3. What do? Should we just send the kid away? Oh, you know what? It's too severe. You know, one day you're going to get your jaw chopped. I think it's always worthwhile to give each of the growing kid a chance and see how the growth potential express itself. So we did the bonded RPE with a face mask, and then continued with fixed appliances, and this was her result. And I think we had to say that we achieved something quite significant for that individual of improving her psychosocial development. I'm not sure whether, because in Indonesia sometimes we say that if you have that kind of jaw, your luckiness becomes greater. I don't know whether that's actually evidence-based though. Okay, then that case was presented at the Taiwan Association of Orthodontists conference as well as the Singapore conference. The next case is a camouflage case. Quite severe class 3 as well, with a history of a palatoplasty when he was very young. And you look intraorally, there's a bit of asymmetry, but patient was not really concerned about that, but mostly concerned about the smile. Ideally, this would have been a surgical case. But again, not many would have the opportunity to do that, or nor they are willing to do that. So we offered to do a camouflage treatment on this case. This was also done by one of my residents who now has become one of our junior staff in our department. I'm just going to talk briefly how the case progresses. That's within 26 months, with an evidence of expansion. We can see there is still a little bit of that asymmetry, but patient was happy, and the good thing is patient is now married, which is a good thing. Yeah? That means our result was accepted by the market. If not, I'll be in trouble. The mother will complain to me. And the good thing is we have published this in the American Journal of Orthodontics. I think that was one of the first case report from Indonesia as well from our university. So we were quite glad about this. But again, this is how we try to incorporate what we are doing, even in the clinical setting, with evidence. But again, if you look at these two cases, sometimes people ask, how can you get that position right? But again, I must remind you that we need to avoid using undersized wires because the talk expression is influenced by all these factors. And we still hear a lot of people, even the practitioners, using undersized wires in doing their clinical cases. And I asked one of my residents as well to do research using the finite element analysis to show what would be the effect on the torsional play if you use an undersized wire during the finishing. Let me show you again. So you can see the smaller the wire, the more torsional play happening. And the more torsional play means it's just like using round wire. You don't have a 3D control. Again, we try to prove this issue by using a well-defined research. And if somebody still don't believe it, it's up to them, up to the clinician. Another camouflage case is a severe class 2 div 2 with, well, a little bit dished in profile, but very severe crowding. I mean, I would have extracted this. But we tried to do this on a non-extraction basis as not to further dish in the profile. This was also done by my resident during their residency in the clinic. And that's what we have made the case. You can see evidently the amount of dental expansion that we created. And we presented at the ORMCO APEC Postgraduate Forum, and somehow the resident won the first prize as well. So there are always other ways to do things. There's no black and white cookbook in orthodontics. Then we have this camouflage case as well. He complained about a deviated midline. There was an asymmetry. But when we look and investigate it further, there was a displacement because of the occlusion. So what do we do? Apparently, we're going to do camouflage on this case and also removing 2 lower fours on this case, alleviating the displacement, and somehow we have managed to finish the case in an acceptable way. And my resident presented this at the postgraduate forum of the Singapore conference back in 2019. I think I could fairly say it's just acceptable. Not too perfect, but acceptable. Obviously, also there are cases that my specialty, orthodontics, cannot stand alone. There are cases where I have to work out together with my colleague. When I ask him to perform a surgery-first approach, then we sometimes discuss using his sophisticated software somehow, where he chop her jaw, and somehow it makes my orthodontic treatment much easier in the next phase. So it's not always camouflage. We have to know the difference. And then the last case. My resident also sometimes had to face cases of what I would call as a retreatment of a mutilated case. Probably this is something like Dr. Tami used in the morning, a mutilated case, but it's not dying, but just the case was just looking a bit horrendous. This was treated by 2 of my residents. It looks like this, following after, I think, about 6 or 7 years of careless orthodontic treatment. So that's why I always teach my students, have a heart before you treat your patients. And when I was about to enter the clinic, Professor Hunt one day told me, do to your patient, whatever you want to do to your child, to your spouse, to your family, things you don't want to do, please don't do it to them. And I think I remember that really deeply in my heart. It marks in my heart, and then I always keep saying it to my student, to my postgraduate as well, have a heart. Otherwise, you're a beast. And these two of my residents have managed to at least give back her life in a better way. I think she's happy. Well, despite of all these clinical settings that we do, we also do research, obviously, because we are a part of the university. This is what my head of department designed, these research topics. And then we has developed it to different branches of the trees of research, into different areas. And we managed to get some publications out of those. Sorry about this pointer being a bit slow. We managed one to publish in the Progress in Orthodontics journal on the top left. We also just had a recent publication about cleft by one of my colleagues, Dr. Sandy, in a Q1 journal. And many more. This is just several examples of what our staff did. And some of my students also presented things with posters as well. I think both of them have not written it and published it. I think it's maybe needing a little bit more time to do that. So I think the key point is being competent, but also being critical. But on the other hand, you also need to be creative as well as the clinician. This is a very good video. I think I would like to share it with you guys. How it's the same thing, but from different view, you can see different things. So that's the importance of us, especially in teamwork, having the ability to communicate. Without communication and proper communication, it's just not going to happen. And then also, a very renowned orthodontist, Dr. Sheldon Pack, says conscious clinicians should try to develop individualized treatment plans for their patients and not be influenced by treatment philosophies with untested claims in clinical orthodontics. Everybody need to remember that faithfully in their hearts. And for the youngsters at the back, for the undergraduates, quit believing of what you see on social media as fact and focus on your choices, your goals, your life, and do the work. I need to censor my words. This is a video of my department, the clinical side. And I have to thank my resident, Janet, and also Prilly for helping me to set up this lovely presentation. Otherwise, I belong to the old generation. I'm very much called GAPTech or Gagap technology, or being dumb in technology. This is our orthodontic department clinic and the hospital. This is Prof. Krishnawati giving instructions. This is Dr. Sandy putting tats. I'm not seen in the video. I asked them, don't put me in the video. Scary. And this is part of our social gathering as well. Every year we do this. We go to several different areas in Indonesia to give education as well, doing some clinical examination as well to get data as well for some of the epidemiological research that our staff is doing. That was in Bali though. So this was a picture taken with the boss of UM and my boss on the right. And this is, I have to always say thank you as well to all my colleagues in my department. I think if you look carefully, this photo was actually was created because two persons was not actually in the picture on this event, but we had to do it, otherwise I'll be criticized for doing that. So these are the complete people in my department. So thank you for all my seniors and also my juniors as well. This was our last trip to Lombok, so anyone coming from overseas, do come to Lombok. Very nice beaches and very nice food with ayam taliwang. And terima kasih. Thank you very much.
Thank you, Dr. Benny, for such fruitful insight coming from field of orthodontics. So we come to the Q&A session. I would like to invite the audience to address any questions to Dr. Benny's presentation, maybe one or two.
I think we're all hungry, I think. Makan.
When? Okay.
My resident asked, how dare you?
Okay, thank you for the opportunity. Thank you, Dr. Benny, for the lecture.
Thank you,
it was
Hema.
very inspiring. My name is Hima. I am the resident of Dr. Benny. What I want to ask is, do you think that in the future, artificial intelligence will play a big role, or at least a role in our field? Because, you know, there are a lot of industry that uses deep learning or their technology. And for example, we have WebSef also, that it has digital annotation. What do you think about that? Can you enlighten us? Thank you.
Thank you, Hema, for the question. She has the courage to ask me. But thank you. I appreciate that, Hima. You're very good. I think we're not anti-technology. We're not here to be anti-technology. In one way or the other, we have to adapt with this developing new revolution with the AI. But I think I'm still quite old-fashioned as well. Maybe like my teachers in the UK, they were old-fashioned as well. But there's always a good thing of being old-fashioned. You need to understand the basics first before you just jump into relying yourself with the AI. I would say if someone relies too much with the AI, sorry to say, you become D-U-M-B or dumb, okay? So in a way, like what I showed earlier in the slides, like certain treatment mechanics now we are using, like clear aligners, they're relying heavily on using softwares. But softwares, again, they have proven it in the research that the accuracy was not as what they claim. And the last one, the 2025, just now, just a few days ago, posted in the American Journal of Orthodontics, 36 outstanding clinicians all throughout the world, including Prof. Ravinanda, which is our friend as well, with the IAO as well, and said, you got to be rational when you want to use this new technology. You don't just use it like a bread and butter mechanics for everyone. Everyone coming to your office, okay, let's get this recognition as a platinum provider, whatever, and then they will get sprinkles upon your face. No, that's not what we are doing. But if you want to choose to be that way, it's up to you. Okay, so I think we need to still adapt and accept this development of this technology, but be aware and be rational. I think that would be my answer. Thank you.
I think we have time limitations, so we could conclude this session. Thank you for your time, Dr. Benny, and thank you for the audience for the attention.
Thank you very much,
So I hand it back to the MC.
Thank you, Prof. Lisa.
Thank you so much for the session. We would like to invite Professor Thandarira Ponthawitat, Association Dean for Research Innovation, the Faculty of Dentistry from Chulalongkorn University, to come up to the stage to present the certificate to our distinguished speaker, Dr. Benny. We also would like to invite the moderator to accept the certificate and gifts from Professor Thandarira.
Once again, thank you so much, Dr. Benny, also Dr. Arya, for this excellent session.
Please give them a warm round of applause.
Okay, so next, we'll be moving on to the topic Managing Cryogenic Dual Species Biofilms, the Emerging Role of Non-Albican Candida.
We would like to welcome Associate Professor Panida Thanyasriso, DDS PhD from Chulalongkorn University, as our distinguished speaker for this session. The session will be moderated by Dr. Chitra Kusumasari, DDS specialized in conservative dentistry, consultant in restoration, PhD from Universitas Indonesia.
Okay, thank you very much for MC. Perhaps I would like to make a correction. So, first of all, good morning, esteemed college from Universitas Indonesia, Chulalongkorn University, University of Malaya, and also our dear students and alumni. And here with us, I saw a representative from Universitas Aisyah Pringseu, Dr. Tias and Dr. Koko. Thank you for coming. So I would like to introduce myself. My name is Citra Fragrancia Theodoria. I am from Department of Oral Biology, Faculty of Dentistry, Universitas Indonesia, and it's such a pleasure to lead this session as a moderator. So we have already heard insightful presentation this morning, and now before we have a break for lunch, we have one more exciting lecture to look forward to. So let me introduce our final speaker for this session, Dr. Panida Tanya Raisang, DDS PhD. So I would like to read her brief CV. Dr. Panida earned her DDS in 2002 from the Faculty of Dentistry, Chulalongkorn University, Bangkok, and later obtained her PhD in Dental Science in 2010 from TMDU, Tokyo Medical and Dental University, Japan. She is currently an associate professor at Department of Microbiology, Faculty of Dentistry, Chulalongkorn University, and also serves as assistant dean for student affairs and alumni relations. So today, she will share her talk entitled Managing Cryogenic Dual Species Biofilms, the Emerging Role of Non-albicans Candida. Without further ado, please welcome Dr. Panida. Please give applause. Yeah.
First of all, I would like to thank you, the local committee, for inviting me to be here today and for your warm welcome. I'm really appreciate. My name is Panida from Department of Microbiology, Faculty of Dentistry, Chulalongkorn University. My talk about today is you have to change a little bit from the clinical part to the preclinical part, okay? Because we will talk about the microbiology, okay? So I would like to share our recent research about the carriology from a new perspective that we consider fungi as an important partner with the bacteria to cause the caries. Okay, so I will walk you through two studies. One is about the silver diamine fluoride or SDF against dual species biofilm, and the second one is about the role of non-albicans candida. First, let me start with how this matter. If you look at this global map, if you look at this global map, you can see that, I cannot point from here. You can see that it's about more than 80% of children in our regions suffer from dental caries. So it means like around 8 out of 10 of children in our country, in our regions. So this is not just the health issue, but it's impact families, quality of life, and also the health system. Okay. Silver diamine fluoride or SDF is the non-invasive dental treatment that can erase the caries and promote and how to say that, and help for the remedializations. This is very helpful because it enhances the patient compliance because it's just simple apply to the surface, to the lesions. So this is a reason why SDF has attract more attention for the clinical use. Sorry, I just a bit nervous because I'm promised that I will finish my talk as soon as possible before lunch. Just a little bit nervous because I have to hurry. At that time that I start our research, the SDF is quite expensive in our country and is not widely accessible, affordable. So this is the challenge that inspires us to develop locally produced SDF formulates. And before I move to the SDF studies, first I want to highlight the major change in what we know about the dental caries. For decades, the caries research focused mainly on the bacteria, especially Streptococcus mutans. But more recent research show that the Candida, the fungi, also involved in this process. You can see from this data from the children with mainly on the, you can look at this data from children with the severe early childhood caries. That the researcher can identify 12 different Candida species in their mouth, and most of them were found in the children with severe cavity compared to the caries-free group, especially Candida albicans and Candida dubrinensis. In the same study, they also show that when Candida albicans co-occur with the S mutant, they found in the case in the severe early childhood, severe ECC about 15% compared to the caries-free groups, and found Candida dubrinensis less common, about 11%, but both cannot found in the control group, in the caries-free groups. Moreover, the important thing is, the most important thing is the children that have Candida albicans and also Streptococcus mutans have a chance to have a caries risk increase is about 130 times. So you can see that when they grow together, it's enhanced cariogenic potential. So with these evidence suggests that Candida albicans and Streptococcus mutans are not simply coexisting, but actively working together to process of the tooth decay. This leads to our first study that we focus on developing the locally produced SDF formulations, and we want to test them. We want to test them against dual species biofilm. So let's move to our research design. We use the dentine block and then randomly allocate into 4 groups. 3 is the different SDF formulations, and the 4th group is the control group, is just the water. After that, we form dual species biofilm on all of these dentine block. And then go to the 7-day pH cycling to mimic the oral conditions. After that, we evaluate two outcomes. One is the anti-biofilm and the effect antimicrobial activity against the biofilm, and the second one is the remineralization effectiveness. Okay, let's move to the key result that we found. You can see that this is the results about the biofilm cell viability. All three SDF formulations decrease the biofilm cell viability as you see in this table. And also for the wet weight that represents the microbial load also decrease about 70% compared to the untreated group, the water group, control groups. SDF, the SEM also confirm our results. You can see that in the control group, the dentine surface covered with the thick microbial mat covered on the surface compared to the other three SDF groups is just remaining few damaged cells. Okay. And for the demineralizations, dentine remineralizations, lesion depth and mineral density were determined, and you can see that all three SDF formulation decrease the lesion depth but increase the mineral density. So this come to our conclusion that SDF, we highlight the potential of SDF as an effective treatment that can inhibit inter-kingdom biofilm and also prevent the mineral loss and lesion progressions. Okay, that is our first study, and then move to the second ones. I think most of study about the Candida and dental caries, they mainly focus on Candida albicans. But recently, the clinical data show us the surprising pattern. This is just example. This data from the children in UAE, they found the Candida topicalis and Candida cruciais show the high prevalence in deep lesion compared to the Candida albicans. And also, if you remember my first, I already mentioned in the first paper that Candida duburiensis also found in the carious regions. So these make us think that if these non-albicans Candida are so commonly found in the cavities, are they actively collaborate with the S mutant to drive the disease, or they just observe with no significant role? This is our objective, the objective of our second study. So before move to our second study, I just want to share about the interaction between Candida albicans and Streptococcus mutant. So they work together in the sucrose-dependent interaction. That means it depends on the sucrose. When S mutants exposed to the sucrose, they produce GTF, glucosyltransferase B, that directly bind to the cell wall of Candida albicans. And after that, they produce lots of glucan, the sticky glucan all around both of them, okay? And these helping them to kind of attached together and also attached to the tooth surface. So in clinic, the evidence in clinic and also in the animal study show that when they grow together, I mean between Candida albicans and strep mutans, they form larger biofilm mass. And also the gene expression study show deeper cooperation between these two microbes. When Candida presents, the presence of Candida albicans let the strep mutant upregulate the gene that relate to the karyogenic potential like EPS synthesis, sugar metabolisms, and acid production. So from these evidence, it's come to our second study. So we wonder how about non-albicans Candida. They may work in the same way as that Candida albicans did or not. So we try to determine. In this study, we grow each Candida species alone and S mutant alone, and also grow both of them together in the ratio that they found. The evidence show that they found in the early childhood caries. So, and for the first part, we determine the biofilm mass by using crystal violet assay and evaluate them by relative to its own the sum of its own single species. Okay, so you can imagine that if they work together, we would expect the dual species biofilm show the higher biofilm mass compared to its own, the sum of its own, okay? And this is a result. We at that time, I'm very exciting that for the S mutant and Candida topicalis, when they grow together, they increase about triple amount of biofilm mass compared to its sums. And you can see that for the Candida albicans and Grabata also increase about double. Okay, so this is very interesting from microbiologists. The next experiment, we want to determine the biofilm pH because it's one of the karyogenic potential, the indicator show the karyogenic potential. So we grow the biofilm in the same way that we did in the crystal violet assay. And during that, we measure the pH as I show here in this slide. Okay, so when this is a result, you can see that at the 36-hour, all of the dual species biofilm have decreased the pH, lower the critical enamel demineralization pH, that is about 5.5, and this is similar as the S mutant alone. So we wonder that how about during the way from the several minutes to the 36 hours, what happened? So we did the kinetics measurements, the kinetic pH measurement, and you can see that all of the dual species biofilm and also Streptococcus mutant alone decrease the pH lower than the critical pH of enamel just 4 hours and maintain this pH until the 36 hours. So this result kind of give me a hint that maybe Candida albicans may not interfere the acid production of the Streptococcus mutans. And for the last experiment, we determine the gene expression of S mutant. We want to know that when they live together, what happened. So we grow the bacteria, grow the biofilm in the same way, and then the RNA do the cDNA synthesis and go to the qPCR. After that, we do the log to fold change relative to S mutant single species. For interpret the result, we change the data into heat map and label that. If it's labeled with the green, it means up regulation, and if the red, it means low down regulations. And you can see the result here that Candida topicalis and crucii upregulate key carriogenic genes like GTFB, GTFD, SCRAB, and CIAR that relate to the EPS synthesis, sugar metabolization, and also the signal transduction system. And these two microbes show the similar as the S mutant when co-culture with Candida albicans. But one that surprised me a lot is you can see the S mutant and Candida dubrinensis. Actually, Candida albicans and Candida dubrinensis is quite similar, but in this case, it shows total different result. For the dubrinensis, it's almost all genes down regulation. So this is still the question that we have to answer. So in summary, we conclude that the interkingdom biofilm go beyond S mutant and Candida albicans, and non-albicans Candida also play a role in the carriogenic potential. And for the last, like a key message, carrier management must address both bacteria and fungi for more effective prevention and treatment. Okay, you have to think about the fungi too. And maybe I think if we gain more data from like next generation sequencing, we may find more microbes that involved in this process. And last, I would like to thank the funding from all of fundings and also my colleagues, my students that make this to study happen. Thank you very much.
Thank you very much for very insightful presentations. Yeah, actually in the field of dentistry, we are common know about Candida albicans, but from this study, we can see there is another potential non-albicans Candida that can be involved in the caries pathogenesis. Yeah. Okay, so now we will open for the discussion. We have one question, perhaps the microphone. Dr. Angki, yeah.
Thank you very much. Very interesting. And actually, yes, my research is almost the same because I'm doing the dual biofilm also. But I just want your opinion in this case, for example, like, to how to fight carriers, because we know that at the end of the day, you have to decrease the burden of these microbes, like in the oral microbiome, of course, this dysbiosis in SEC, of course. So what do you think is more effective in this clinical term, not in the laboratory, of course, but which one is better, using SDF or some antibiotic mouthwash? What do you think? Because nowadays you can see there's a lot of antiseptic mouthwash for children. And also they're good for fungus also, right? Yeah. What is your opinion? Thank you.
Thank you for the questions. I think that it depends on the case. So for SDF, the highlight of the SDF is when the children cannot cooperate. So it's easy, just simple apply to the lesions. So it helps to like erase the caries. We know, I think we all know about the effectiveness of SDF to suppress, not suppress, to stop the caries, right? But the problem is like the color and also some, I think, but I never heard about the bad effect of SDF, because when you use the SDF, it's just like a little volume that you apply on the surface. So in my case, I think it depends on the case that you may use the other linearizing agent or other antimicrobial agent, but it depends on the case for me.
Follow-up questions, yes.
Oh.
And the result is very good because it's not blacken the teeth, and you can use also for adult. So I think I proposed if we can collaborate.
Yeah, sure.
So
I'm very happy.
Yes, thank you very much.
Thank you very much.
Thank you very much, Dr. Anke and Dr. Panida. I think this is a very good chance to have a collaborations with you. So yeah, I think now we can close the sessions. I can see many of us getting hungry. So yeah, now we can close this meeting. And once again, thank you very much. And hopefully we can see you again in the afternoon sessions. Thank you very much, Dr. Panida.
Okay, before we begin the lunch sessions, we would still want to congratulate the speaker as well as the moderator for the certificate and the gift sessions. We would like to invite Associate Professor Dr. Zuraiza Muhammad Zaini from University Malaya to come up to the stage to present the certificate to our distinguished speaker. And now, Professor Zuraiza will present the gift as well as the certificate to Dr. Chitra Fragnancia Theodora MSI PhD as the moderator to close up the session.
Thank you so much, Associate Professor Panida and Dr. Chitra, for sharing this valuable session. Ladies and gentlemen, it is now time for lunch and also Friday prayer. The organizing committee has prepared the snacks and also drinks, which are available near the receptionist desk.
We will reconvene at 1:30 p.m. for the poster session, and until then, we'll see you around. Thank you.